So we're just gonna review what we have discussed last time. Last time we were discussing the acute infection of the lacrimal drainage system, including dacryocytes, and we explored some of the presentation, either the acute attack with ruptured lacrimal sac or fluctuation about to rupture, sometimes resolving subacute attack. It is not always safe, so might be very extensive, involving even the side of the nose, the lower eyelid, preseptal cellulitis, mimicking orbital cellulitis, which you will be able to identify after responding to antibiotic, sometimes forming diverticulum involving the whole eyelid, which will be only detected during surgery like this patient. This video, I think it wasn't working last time. So here, when we irrigated the lacrimal drainage system, you can see the fluorescence is coming out. So we confirm the etiology of acute dacryocystitis as a predisposing factor for this massive preseptal cellulitis and even necrotizing fasciitis. It might be so severe, inducing orbital cellulitis, as you can see here. And this is during drainage. Also, we confirm it with irrigation of fluorescent that the acute dacryocystitis is the etiology of this orbital cellulitis. We stopped at this slide. So we'll start with Abdullah. Can you hear me, Abdullah? I can't hear you. Okay. So you can unmute yourself, Abdullah, and tell me what you expect from this slide.
السلام عليكم.
وعليكم السلام.
حياك الله بروف، كيف الحال؟
عبد الله الموسى.
just watching يعني.
لا
تحرجنا يا بروف.
This patient يا عبد الله.
والله lacrimal sac. I would ask يعني if there is any pain ولا.
No, he hasn't been, and just delivered his 7 days.
Okay.
نشوف إيمان الشريف. هلا إيمان.
السلام عليكم بروف.
السلام ورحمة الله، كيف؟
الحمد لله، كيف حالك بروف؟
الحمد لله بنعمة، كيفك يا إيمان؟
الحمد لله بخير بروف.
Senior resident or fellow, so what do you think?
So yes, you mentioned that he's a newborn baby, so most likely, I'll jump to the diagnosis. Most likely this is a dacryocystosis.
Very good. Okay.
طبعا there is other differential, but given the location where it looks like it is below the medial canthal tendon, it is most likely a dacryocystosis, but we should consider also other possibilities, including capillary hemangioma, encephalocele, or meningoencephalocele as well.
Excellent. This patient actually presented with snoring and difficult breathing.
Yes. So it looks like because newborns are usually obligate nasal breathers, it might cause obstruction of the obstruction of breathing. Basically, it might affect breathing, and this is an indication for treatment. So shall I proceed with treatment, Prof?
So how do you confirm that it is a dacryocystosis? Does it have another name, Iman? How do we call it?
There are other names, but للأمانة I cannot recall it right now.
Yeah, it might be seal, although some they are differentiating both the amniotic if the entrapped content is amniotic fluid.
Amniotic fluid.
Seal is the secretion from the epithelium of the lacrimal drainage system.
Yes.
So
we can, to confirm it, we can consider imaging in this child, just to rule out the other differential diagnosis before proceeding with anything. So basically,
the image that we've done for him.
Yes, a CT scan.
This one. What we call it?
So, I cannot hear you clearly.
Yeah, the third one.
The picture?
Oh. Can you
Yeah,
see
this is a, yes, I can see the endoscope, and I can see the, on the lower picture, there is a coronal CT scan coronal section. It is showing, I cannot see clearly the nasolacrimal system, but it looks like the right side is different compared to the left side.
Yes.
But I cannot see the dacrocystocele clearly.
Yeah,
This
this is
one?
the
Okay.
and this is the contrast material within the sac. We
Okay.
we went with probing and we injected the material inside.
Okay.
So this is the dacrocystogram.
Okay.
So what are you gonna do for her or for him?
So initially, since it is unilateral, so I mean it's not bilateral affecting breathing. يعني definitely we can start conservatively with massage. Advise the parents to do massage, and we can like observe for 1 week. If there is no improvement after 1 week, we can go for probing and stenting in this case.
Okay, very
So
good.
plus
Yeah.
minus antibiotic, I think it's controversial since there is no clear signs of infection at this point, but we can consider also giving prophylactic antibiotics.
Yes. By the way, probing, we can do it here without anesthesia. You just go hold the child's head and go with probing. But as long as she has a nasal masses like this, it is better to go with endoscope and do what we call it marsupialization.
Okay.
Okay. Marsupialization will have more successful outcome, and it relieves the snoring and the difficult breathing.
Okay.
Very good. Thank you. Thank you.
Yeah. You're welcome. يعطيك العافية, Prof.
Okay, Dalal. What you see, Dalal here?
السلام عليكم. كيف حالك بروف؟
كيفك يا دلال؟
الحمد لله. Prof, I just want to ask you about the previous case. الحين يعني when we see the patient clinically, especially like given the history of يعني newborn, sometimes it's a clinical diagnosis. Do we need to subject them to imaging and like CT scan يعني for a baby?
Usually we don't, unless it causes difficult breathing and the issue is confusing. This patient was a confusing issue, and he was referred from ENT, so we weren't quite sure about the nasal anatomy and the inside of the airway. This is why.
Okay.
But usually we don't need imaging. Just during OR and go with the endoscope and see if it is he has a mass, or we can do nasal just evaluation in the clinic, because the mass sometimes is so big that you will be able to see it even with the nasal speculum.
Okay. Okay, so regarding this picture, I can see an opening of the skin at the lacrimal area. It looks to be like a fistula at the lacrimal fistula. I don't see signs of like current swelling and dacryocystitis, signs of like current inflammation or infection at this area. On examination, I would examine the whole area. I do maybe just irrigation in the clinic depending on the age to see if I have any like fluid coming out of the area. And I think that's it. Make sure there's no infection and to confirm the diagnosis with the irrigation.
So is it important to identify, is it a congenital fistula from a acquired fistula?
So the history, if it was acquired due to frequent infections, I think there'd be like obstruction. He needs a whole irrigation of the whole system.
Yes. So if it is acquired, means that treatment is mandatory. You have to release it. If the patient is complaining, if he's not complaining, the age, should we wait? Should we go ahead and do it? It depends upon the complaint. How do you manage this to them? If this patient has obstruction, so intraoperatively, what are you going to do?
If he has obstruction?
Yes.
So we'd have to firstly excise this tract of the fistula, excise the whole tract, and then do complete complete intubation of the system, and seeing if the patient intraoperatively needs a stent. I think here we would consider it a complicated case, so we would consider adding a stent.
Very good. So you manage the obstruction as usual. If it is adult DCR, pediatric, you can put on intubation, but you have to excise the fistula, putting Bowman probe and try to do whole excision of the epithelium. Okay, from the skin, that's which are better into layers. Very good.
Thank you, Prof.
Okay, we need one of the junior who is us here. طيب هبة، كيفك يا هبة؟
الو، السلام عليكم بروف.
السلام ورحمة الله.
عليكم بروف.
Yes. Can you?
Yes, Prof. Can you hear me well?
Yeah, just tell me what you see and what you expect to have.
Okay, I'm seeing a lower lid medial mass that doesn't look erythematous or painful for the patient. I can't see signs of inflammation. If it is quiet. So in this case, I would like to rule out a mass, a tumor, since there is no significant inflammation.
Okay.
I would ask in the history more about the mass, the onset, the progression. Is there any? Yes, Prof. Is there any pain? Is there any bloody tears? Is there any previous traumas or any previous surgeries? What about the other eye? Is there any previous history of ocular cystitis? And that's the main things that I would like to ask.
Most likely, the first diagnosis in your mind is
ocular cystitis in this case, but there is no signs of inflammation.
Again, ocular cystitis. Which type of ocular cystitis?
A chronic ocular cystitis.
Okay. So very important to identify which type. All the previous slides were acute. So this is a chronic ocular cystitis.
Yes.
How do you confirm chronic ocular cystitis?
By the regurgitation test, there would be a blockage.
Okay, so you will press on this mass and you will have positive regard of discharge, mucoid, mucopurulent, purulent, whatsoever. Okay? Yes. If the patient has this mass and you pressed and there is no discharge coming from the puncti, what could be?
Both puncti?
No discharge is coming, no regurg. But there is a cystic mass in this area.
It is cystic in consistency?
Yes. I think it could be a mucocele.
But it could be, yeah, it could be. For her age, yes, it could be, or his age.
So it is not mandatory to have a positive regurg. It might be a mucocele entrapped secretion within the lacrimal sac if the common cariparus is obstructed and nasolacrimal duct. Sometimes the patient, when you press, there is nothing coming through the puncti, but the patient feels discharge in the nose. So the obstruction is complete at the common cariparus, but it is partial at the nasolacrimal duct. But this is usually in the beginning of the condition. Later on, the obstruction will be up and down. Very good, yeah. How do you manage chronic ocular cystitis? This is the positive, and I'm going to show you the this video. Can you see it here, Iman?
Yes, it is clear.
Okay, you see the discharge is coming?
Yeah, there's discharge coming, mucoid discharge. Yeah, it is yellow in color. Or is it fluorescein or is it fluorescein?
Yeah, if the lacrimal drainage system is patent until the lacrimal sac, if you put fluorescein inside the conjunctival cul-de-sac, you will have some discharge coming with fluorescein. Yes. But it won't be a huge amount of fluorescein because just it seeps around and went inside, but it won't drain through the nasolacrimal duct. So if you have a chronic ocular cystitis in the clinic, what is the next step? First, what is the site of the obstruction in this particular patient?
It is I can't recall.
Okay, is it in the common canaliculus? Is it in the nasolacrimal duct? Is it,
It is
can be
nasolacrimal.
confined?
Nasolacrimal duct, it is.
Nasolacrimal. Are you sure about that? Do you need to go for any confirmation test? Or when the patient has positive regurg, it is a nasolacrimal duct?
Yes, yeah. Whenever we have positive regurgitation, it is nasolacrimal duct obstruction.
Excellent. Excellent. Very good. It might be confusing when you press on the lower area here, you will see the positive regurg coming from up because
Yes.
you kinked the lower one. But if you pull the lower lid down and press here, you will probably have clear discharge coming from both upper and lower puncti. So in this case, no need to go for any further confirmation, and this is a nasolacrimal duct obstruction. Usually in adults, this is a primary acquired nasolacrimal duct obstruction, what we call it BANDU.
Yes.
Okay, but when you should go for probing,
And
like this to confirm.
when
If you have a
when
positive
we
regurg, patient has epiphora, but
yes,
he hasn't a positive regurg. In this
when we have
situation, you have to identify where is the site of obstruction. Is it in the canalicular, common canalicular, or nasolacrimal duct obstruction? Why it is important to do this?
to know the type of the surgery that we will choose.
Well, so number one, the type of the surgery. If the obstruction at the level of the nasolacrimal duct or common canaliculus, the treatment is
We'll go with DCR,
DCR. If the obstruction at the canalicular level,
CDCR then.
CTR, it depends upon the area which is patent. Usually we go with the probe and hold it with forceps here and measure the area which went inside. If it is 7 millimeters or more, you can go for chance DCR. Okay, you might use the Sesler or whatever the method that used to release the area of obstruction. But if the obstruction is less than 7 millimeter, DCR is unlikely to work. So you have to go for CDCR. If the obstruction at the level of the common canaliculus, so when you irrigate it, the fluorescein or the saline is coming from the lower one. Or if you irrigate from the lower one, it comes from the upper one. So in this situation, the patient might have common canalicular versus nasolacrimal duct. So in this, you have to go for probing. If you feel bony part here, we call it hard stop. This is a nasolacrimal duct. If it's soft stop like this one, it is common canalicular. Why it is important to differentiate between both, although the treatment is the same? We're going to go for DCR, whatever the etiology, the location of the obstruction.
Whether we will put stent or not?
The duration of stent. And I do agree with you because nasolacrimal duct sometimes is not mandatory to go for stenting if the canalicular system is fine. But common canaliculus, you will put a stent, and if you decide to put a stent also in nasolacrimal duct, common canalicular stent has to be left for a longer duration, usually 5 to 6 months.
Okay.
But before that, the decision for surgery, I'm going to give you two scenarios. If you have 70 years old patient with common canalicular obstruction and another 70 years old patient with nasolacrimal duct obstruction, so does it matter the site of the obstruction here in this age?
With the age of with that age, with 70 years old lady?
Yeah, 70, yes.
I'm not
Okay.
sure.
If the patient has common canalicular obstruction, do you think that there is a possibility to have acute infection of the lacrimal drain system?
Yes, she might have. Yeah. With the
Okay.
the canalicular system obstructed?
Yeah, if the common canaliculus is obstructed.
No, she will not have it. No.
Okay, so it is unlikely.
Yeah.
Okay. Yeah, because usually if the tear is not going through the lacrimal drain system, there will be some metaplasia here and the nasolacrimal duct will be obstructed.
Yes.
So the incidence of infection is very unlikely. And patient is likely to have dry eye, elderly female after menopausal, if she's hypertensive, using anti-hypertensive treatment, she's diabetic, whatsoever. So in this situation, the decision of surgery is the patient decision. If she's really bothered with epiphora, you go for surgery. If not, better not to operate. But if there is nasolacrimal duct obstruction and hard stop, no, the story is different. Now we have reservoir here of tear that might get infected and patient might have acute or chronic infection. So the decision now is to go for surgery. So you have to Yeah, exactly. We have to recommend surgery for her. Unlike the first case, she will be the one who will take the surgery. Clear يا إيمان؟ يا
Yes,
واهبة؟
yes, Prof.
أو well done. Thank you. كيفك يا شيخة؟ السلام عليكم. Can you hear me, شيخة? Okay, I think can't hear her. طيب. This is somehow difficult, so we need فادي. كيفك يا فادي؟ Can you hear me, فادي؟ طيب. ريم العنزي. Okay. Let's see here. وليد.
هلا بروف.
هلا وليد، اخبارك ايه؟
يا رب سلمت.
على قدر اهل العزم تؤتى العزائم يا وليد.
الله يرفع قدرك يا رب.
الله يخليك يا وليد. So what do you think here? This patient is complaining of chronic conjunctivitis for more than 2 months. She's using topical antibiotic. Showed some improvement, then the condition recurs once she stopped the antibiotic treatment.
طيب ممتاز. So this is an external photo that shows everted lower lid with clear papillary conjunctivitis, and the lower punctum looks stenosed, and the bulbar conjunctiva is quiet.
Okay. This is a close-up view of the lower punctum.
Yeah, so it looks like there is a severe punctal stenosis.
Okay. So your diagnosis is punctal stenosis.
Yes.
Why she has a chronic indolent conjunctivitis?
Well, the most likely cause of her punctal stenosis in this case is the chronic papillary conjunctivitis, most likely to the preservatives she's taking.
Okay, but why she has discharge which improved with antibiotic and then relapsed again? Right, I'll make it easier for you, So now this is a severer form of the previous patient. So what could be?
This could be chlamydia conjunctivitis.
Chlamydia conjunctivitis. Okay. Right, I'll give you a hint for the previous patient. Actually, what we see here is milky, scanty discharge coming from the punctum when we press on the lower eyelid or the lacrimal sac area.
So there is a positive discharge coming out of the punctum.
Yeah, but it is not the huge amount of discharge that we see in chronic dacryocystitis. This is a scanty and somehow milky discharge.
Is there any granules coming out of the punctum?
No granules coming out. But you are heading the right way. You are heading the right track.
So the patient has chronic conjunctivitis,
Okay.
which is causing her punctal stenosis in this case. This is the upper lid. This is the granules coming out of the punctum.
Okay.
So the diagnosis is canaliculitis.
Very good. So whenever you see our chronic conjunctivitis indolent, not responding to treatment, always think about canaliculitis. Okay. Especially if you press on the canaliculus, you'll find very scanty discharge. We don't expect that the granules will come out because it is too big than the punctum side to be expressed out of the punctum. In rare instance, if the patient had punctal blood, it is a secondary form of canaliculitis. So the punctal plug might be went inside or impacted and causing the canaliculitis. How would you treat canaliculitis, Shari?
So for patients with canaliculitis, I would start with warm compresses, topical antibiotics QID, and then I would proceed with canaliculotomy, irrigation with penicillin or iodine.
Okay, very good. So the conservative treatment, it is usually filled in more than 80%. So the ideal treatment is to do canaliculotomy and curettage the content and take out the granules, sulfur granules. Usually the microorganism is
Actinomyces israeli.
okay. We used to tell that this is by far the most common, but nowadays, no, we have strep, staph, and even Pseudomonas if it is due to punctal plug. Okay, so curettage is very important. Sometimes you do cleansing for spoon to take also the infected mucosa and irrigate the lacrimal drain system and use systemic topical antibiotic. The best is penicillin G, but the patient has to come on a daily basis. Quinolone will be effective like Oflox or Vigamox. Okay. Sometimes the inflammation is not evident, but the punctum is swollen like this, the canalicular system. So this is another patient with the granules. Okay. Very good. Yeah. وليد ربنا يبارك فيك. شكرا جزيلا يا وليد. الله يخليك. طيب فيصل. Can you hear me, فيصل؟
السلام عليكم بروف.
عليكم السلام، كيفك يا فيصل؟
الحمد لله. ما أعرف إذا بروف صوتي واضح ولا لأنه
I can hear you clearly يا فيصل.
الحمد لله. So this is a external photo of what seems to be a child.
Very good.
With a lower lid, what seems to be laceration here. I can say that there is a it's extending superficially to the margin, but it's not clear from this photo. I can't comment if it's involving the lacrimal system from this photo alone. I might need another view. And also I cannot comment on the eye itself from this photo.
So your primary objective is to rule out globe injury?
Yes.
Very good. And second is to rule out lid margin involvement or canalicular involvement?
Exactly.
As we are talking about lacrimal drain system now, so the canalicular involvement, how do you confirm or to rule out damage of the canalicular system?
By first examining the punctum and see the extent of the injury. If it's first lateral or temporal to the punctum, it's away most likely from the punctum, خلاص. But if it's medial, no, for this not this location in general. I mean, but for this location,
yes.
What we can do is we can. Sometimes it's very obvious on examination, so we don't really need to. But in this case, we might need to irrigate, and we can see if with fluorescein dye, maybe we can see if it's coming out from somewhere or not, from the wound itself. I mean.
So here it seems that it is lateral to the punctum, so it's unlikely, but we are not quite sure. Okay.
Yes.
If we invert to the eyelid and the conjunctiva is involved with medial to the punctum, mostly the canalicular system is damaged. If the punctum, the lower punctum is slightly lateral to the upper. So if the upper is here, the lower will be slightly lateral, but the edges are opposite each other. But if it is displaced laterally, markedly mean that the medial palpebral ligament had been torn. And if the trauma is severe to affect the medial palpebral ligament, it usually cuts the canaliculus.
Canaliculus, yes.
This is another patient, adults, and this is how to confirm it by passing
Totally.
the
Yes.
radiation. Okay, but before doing this, always tell the patient and the family that we're gonna explore the lacrimal drain system to be sure it is intact or damaged, because they might accuse you that you are the one who damaged the canalicular system.
Yeah.
Okay, this one is
So-
more clear because it is
Yes.
medially. Okay, so how would you manage the canalicular lower lid laceration with canalicular damage?
This has to be repaired surgically, ideally by someone who's experienced with oculoplastic surgery. I saw what we usually do is by two methods: by either the pigtail, by passing it through in this case the normal canaliculus, and then going through the lower, or with mini Manuka stent.
Okay, so if you have the experience, do it. If you don't have the experience, defer it. Or even if you did not repair the canalicular system, it is not mandatory that the patient with canalicular obstruction will have edephora or canalicular damage will have canalicular obstruction. Very
Yes.
good. Yeah. Sometimes it is very severe like this, and you can see the cut here.
Yes.
And here you can see the cut of the lacrimal drain system. These are the type of stent that we usually use. The non-canalicular with self-retaining. It comes in different shape. It might be only small area if you do it under local anesthesia and the obstruction or the cut is lateral or near to the punctum, away from the common canaliculus. You can use the red link, whatsoever is available in your. This is how to repair it, Faisal.
Yes.
You use the monocanalicular stent. So dilate the punctum. Don't dilate the liver, otherwise you will rupture the canalicular system. So you'll be able to identify the medial cut end, which is exactly opposite the lateral cut end. As you can see, some glistening mucosa here, this glistening area around, which identify the canalicular system. If you are not quite sure, you might irrigate the lower one with fluorescein or use pigtail if the cut end is so medial. With irrigation, you have to irrigate very slowly to be able to see the flush of fluorescein coming out through the punctum. You can see it here.
Yes.
The cut end. Okay. Pigtail has some pros and cons. If you are not expert, don't try it because it probably damages the canalicular. This is the monostent. We'll put it first here after dilating, and with swelling we'll be able to engage the shoulder of the punctum self-retaining the punctum blood. So monostent. So you might help yourself by pushing it. Be sure that the collaret is aligned with the lid margin. Meters, and the cuttets, you sure that it is inside the lacrimal sac. If you are on the right track, once you put the tab, it will slide inside the canalicular system. And then suture with 8 ovicral around the canalicular system. Don't engage the epithelium of the canalicular system. Don't take much suture, 1 or 2 will be enough. Okay. And align the eyelid. It is important. Yes, it is important not to invert or invert the eyelid. So the position of the eyelid should be aligned. And you may remove the stitches after 5 to 7 days, or it is likely it is absorbable. And usually use the stent for 2 months. And this is another type of stent. Thank you, Faisal.
Yes. Thank you, Prof.
You're welcome. I can see here iPhone. I don't know who is the iPhone. بدور السلمان. كيفك يا بدور؟
السلام عليكم بروف، كيف حالك؟
السلام. الحمد لله بنعمة يا بدور. What do you think here يا بدور؟
Here we can see intubation of both the upper and lower canalicular system.
Okay. So which type of stent is this one? He has trauma here on the upper eyelid. You can see cut wound involving the canalicular system. So if you look at the stent and you find this color, which type of stent is this one?
This is bicanalicular stent, but I'm not sure which type.
Okay. طيب خلينا نشوف دلال. لأن دلال she had good experience with this.
Yes, Prof.
Yes, yeah. Which type of stent is this one?
I think this looks like a Bowman probe.
Bowman
It's clear,
stent.
but then there's blue. I'm not sure, Prof. They both look similar when they're attached, but this looks like a Bowman because it's the one that we tied, the bicanalicular Bowman stent.
Iman. Sheikh is around or not yet?
Assalamu alaikum, Prof.
Yes, Iman. Which type of stent?
I think, Prof, it's the Rittling stent.
Sorry?
I'm not sure if I'm pronouncing it right. Rittling or Rittling?
Rittling stent.
Yes.
Right. We'll make it easier. What is the diagnosis here?
The punctum looks stenosed or actually حتى even occluded.
Okay, so this is a punctal phimosis or punctal stenosis. Actually, we divide the punctal phimosis or punctal stenosis into grades. So this is a normal punctum here, might be slightly dilated. This is mild stenotic, but we can see the lumen here. Sometimes very hard to see the lumen, or you cannot see it. This is a mild degree. This is mild to moderate. If you cannot see here only the membrane, you cannot see the lumen here, but you can identify where is the punctum. This is a moderate degree. And finally, if you cannot identify where is the punctum, this is a severe degree of punctal obstruction. The treatment of punctal phimosis now, this photo might be easier to identify. So which type of stent now? With the blue line here.
To be honest, I haven't seen this stent before, the one with the blue line, so I'm not sure.
Have you heard about pigtail probing?
Yes, yeah, pigtail. Okay.
So the pigtail,
it comes.
Yeah, the stent itself, it is colorless, but because we have
bleeding.
Exactly. Okay. So this is the pigtail. And as up and down, so you can go through the upper punctum or lower punctum, and the dilator, nettle chip dilator, the fine one, and the plumb tip. So this is how to do it. You go with the punctal dilator. After that, you put the pigtail, and be careful while you are putting the pigtail because 10 to 15% of the normal population, they don't have common cariculus. And
so
successful mainly on the presence of common cariculus. So you have to go with the pigtail, and once you feel it, you are inside the lacrimal sac. You feel some resistance that giving away. So go back and try to get into the other canaliculated system. Once it gets out, as you can see it here, you will put the 6O proline through this opening, get it out, as you can see here. And then you bring the stent and put the suture inside. So the idea here that the suture will be your guide through the canalicular system. And then try to put it inside. As you can see here, you might trim it off if it is long. And after you trim it off, you have to put the proline back and tie it. After you finish tying it with multiple 3 throws, you'll find the sticking out here, the knot. And you cannot leave it like this. You have severe foreign body sensation and canalicular also irritation. So you have to milk it inside the tube, as you can see it here. Put it inside completely. And once it is inside, then you rotate the knot with the stent. It will be inside the canalicular system. And this is a video how we do it. So the punctum, as you can see, be sure that the rest of the canalicular system is patent, because it does not mean anything if you put a stent here and the nasolacrimal duct is obstructed. Gently try to engage the stent, the pigtail probe, the other side. Once it comes out here, it has a hole. You always use the blunt tip, because some they are coming sharp. Don't use the sharp. Sharp is very dangerous and damaging to the lacrimal drainage system. Once you put in through it, take it out, and then measure 20 millimeters or slightly bigger according to the age and the nasal bridge. Cut it. When you cut it, it has to be, as you can see here, perpendicular to the tube. So don't make edge, because if it has edge, when you close the loop, it will be having a pointing part which will bother the patient. And then put it inside. Putting inside. If you pull the lower one, it will be straightened and will go inside, and you will see the other end coming from the lower punctum. Adjust the length. If like this patient, it is longer than what should be, because you don't need it to hit the cornea, so you can cut a part of it, but be careful that the stent now, the suture, you cannot hold it, so gently try to put it inside again, and we'll tie it, multiple 3 throws. And then you cut, and as I told you, milk it inside. So the knot and the edge of the knot will be inside the stent itself, so it won't damage the canalicular system. Patient will not have any foreign body sensation, and then rotate it inside.
Okay. Prof, I have a question. If you want to remove it, هل في طريقة معينة to remove it, or just cut it and pull it?
You have to rotate it again, so you will have the top end in front of you, and then cut in between the stent while holding the stent with the suture inside and pull it out.
Okay, so suture should be inside the stent, so not to damage the system.
Don't cut the stent itself. So you have to pull it again, rotate it again. So you'll have now not in front of you the area between the stent and the cut only the suture, and then pull it out.
I'll cut the suture. Okay. Okay, clear.
Okay, clear the pigtail.
Yes, clear, very clear. يعطيك العافية.
Sometimes after you remove the stent, the punctum is really wide like this, and usually the patient will be happy, unless if he has allergic conjunctivitis. Be careful, you have to treat allergy because it tends to come back. The stent is not always safe, so you might have infection around the stent. if you developed any infection or pyogenic granuloma, you have to remove the stent even earlier. And once you remove the stent, you can see the eye is becoming quiet again. You see there is a pyogenic granuloma here around the stent, might be in the upper, the lower with metaplasia. And this is not the big tail, because big tail, you should see the blue suture inside. Okay. This is a regular stent. This is a big tail, you can see the suture inside. So sometimes if it is too tight, it might causing slit canaliculus. This is why it is advisable to adjust the stent size before tying your suture. Don't make it too tight, don't make it too big, so it won't hit the cornea. These are different shapes of slit canaliculus. This is a suture that had been taken to repair canalicular system and wasn't in the right way. When you cut the stent, especially in congenital nasolacrimal duct obstruction, be sure that the knot is out. Yeah. Otherwise, you may leave the knot inside, like this patient, and he will have dacryolis and chronic dacryocystitis that might be state DCR. Okay. Thank you, Ayman.
يعطيك العافية.
R1. ريم العنزي.
هلا دكتور.
هلا، اخبارك ايه؟ وعليكم السلام ورحمه الله وبركاته. كيفك يا ريم؟ الحمد لله. So, what do you think about this patient?
Okay, this is a child with we put fluorescein dye in both eyes. We're trying to do a dye disappearance test and Jones test also. And you may see the result on the right side. There is retention of the fluorescein dye in the right side with the negative Jones test. The left side is clear with the patent nasolacrimal drainage system and positive Jones one.
Very good. So the diagnosis here is
nasolacrimal duct obstruction on the right side.
Right side. Okay. Sometimes if you cannot see the fluorescein, you might go inside with the Q-tips. The nasopharyngeal swab, this one is very thin, so it won't irritate the child very much. And when you go inside, you have to go perpendicular to the parallel to the nasal floor and perpendicular to the nasal cavity. And you have to go for 1 inch in pediatric age group and 4 centimeter in adults to get into the nasolacrimal duct opening in the inferior meatus. The blue filter is good to identify the fluorescein if it is not that clear. And how do we manage congenital nasolacrimal duct obstruction?
Depend on the age first. If the child below the age of 1 year and there is no severe infection or the attack of dacryocystitis, so we try first with the massage.
Okay. How do we do massage? This is very important.
Yeah, the massage usually we should do it over the sac itself and frequent time, usually during breastfeeding, more than five times a day.
Yeah, we used to tell the patient use your finger and little finger and do it in like what we described as curricular massage and push it down. But if you think about it, the little finger is too big for the child. It has nail, so the best way is to use Q-tips like here, just to go over the lacrimal sac area, pull the upper eyelid up so you won't damage the eye, and do massage, and that's it. No need to go this way, because here this is a bony nasolacrimal duct. So if you go this way, as if you did nothing. So all what you have to do is to pull the eyelid up, so you won't damage the inner aspect of the globe with the conjunctiva, and do massage as shown here. This is the best way. You might put ointment here, so with time you won't damage the skin of the child, and you have to do it 3 times a day, every time 10 massages. for the first year. Mostly, if it's not responding, be sure that the massage was done in a proper way, because this is the most common etiology of ineffective massage. Then, if it is not responding until the age of 1 year, we'll go for probing plus minus stent. Putting the stent is an intraoperative decision. This is how to feel hard metal on metal. So you have to go perpendicular to the head, to the table, and 15 degrees to hit the probe. Then you go with different types of intubation, either the Baker type, Baker baby, or Bowman probe, the Crawford probe with olive tip, or you can go with the rattling technique, whatever is available and whatever you master. This one is the least traumatic, followed by this one, and this is the very traumatic, so you have to be familiar with the use of this type. This is a punctal phimosis. How to remove the stent?
Pediatric, usually we do it under sedation better, because unless the patient is cooperative. We should pull it from the superior punctum, and until we see the knot, and then we cut below the knot and would pull it from one side.
Okay, very good. First, don't remove stent of somebody that you don't know how he had done it, because some surgeons, they fix it with a black suture or engage the nasal mucosa. So when you pull it, either the suture will not come out, or the stent will cut and the suture will stay inside the lacrimal sac, causing dacryolysis, or your patient will have bleeding from the nose if you pull it with non-absorbable suture cutting through the nasal mucosa. And in our hospital, we do it only without fixation to the nose, just 4 knots, which is thin that you can pull it from outside. No need for sedation, just to hold the baby. Hold the stent, as you can see it here. Just usually I manipulate the upper punctum, so I do it from the upper one. If the surgeon is manipulating the lower one, dilating the lower one, he can do it through the lower one. Keep pulling till you have the knot out. Don't cut the stent unless you have the knot out. Okay. And it comes easily, by the way. Once the knot is out, just cut it medial to the knot. So when you pull it, it comes completely with you. Okay. Clear? Do you have any question? I can't hear you.
يعطيك العافية دكتور.
If the knot is inside, because sometimes if you remove the stent of somebody and you don't know the technique, like this child who presented with chronic dacryocytes after removal of the stent, which wasn't complete. Let us go. We tried to put it this way, it did not work. So we had to open the lacrimal sac, as you can see here, like DCR. And this is exactly what I had mentioned.
Same steps of DCR, doctor?
Yeah, same like DCR, but don't remove the bone. Just the lacrimal sac, the medial aspect, open the lacrimal sac, and find out the remained part of the stent, as you can see here.
Here the silk suture is.
This is the stent with the suture. So what they have done, they just pulled the stent from the puncti, from the eye, and they cut it this way. I will just adjust it now. Okay, yeah, like this way, and they cut the stent to the upper and lower stent this way. So they left the knot inside the lacrimal sac. So it worked like a stone, causing dacryolysis. Ended up with dacryocystitis. We did not do here DCR because the etiology we know it, so just fixes the stent and we sutured the lacrimal sac. The patient went fine after.
دكتور بس سؤال لافك. What about the endoscope, the role of endoscope in removal of remaining stent?
Yeah, the endoscope, if the stent hadn't been removed, so you can go with the endoscope to see it from inside the nose. But this is, you have to do it if you don't know the technique of putting the stent. But if you put the stent out or the stent is coming through the punctum, mean that the knot is already inside the lacrimal drainage system, either impacted within the nasolacrimal duct or within the lacrimal sac. So with the nasal endoscope, you'll not be able to see it. Okay, this is what we call it the tear meniscus, and how to evaluate the tear meniscus in patient with watery eye. You can put the fluorescent to highlight it, and this is the tear meniscus between the posterior border of the eyelid margin and the ocular surface. This is a mosaic appearance to evaluate the oily layer. So like specular reflection, make the slit lamp 90 degrees, the visualization piece and the illumination piece, and it has to bisect bisected by the eye. So the illumination piece will be 45 degrees, and the eye piece with blinking and high magnification, you will be able to see the mosaic appearance of the lipid layer. We have a machine to measure it. We call it tear film analyzer. This is the lacrimal sac fossa. Always remember that the posterior lacrimal crest here is part of the lacrimal bone. It is not a maxillary bone, and we have to stop here. We should not take this one in DCR because the medial palpebral ligament is the posterior cross is attached here, and the anterior cross is here. We usually detach the anterior cross, either to cut it, as some surgeons doing it, or just evert it with the periosteum. So we usually start the osteotomy at this area, the same area of the bone here, and it has to include the whole anterior lacrimal crest. Very important landmark here, the anterior ethmoid and posterior ethmoid here. And this is around 24 millimeters, so this is 1 inch from here, and this is 12 millimeter behind, so 1.5 inch. So when you give local anesthesia for the lacrimal sac in DCR, don't use 1 inch needle. You might damage the anterior ethmoid and you'll have orbital hemorrhage when you give infratrochlear or supratrochlear injection. This is very important landmark even in FIS or on medial wall decompression, because here is the base of the scalp. So don't reach this area. This is where we are doing the lacrimal osteotomy and DCR, and this is anterior and posterior lacrimal. This is very important DCR as anatomy. So who will take this one? Ali Yasin. Okay, Abdullah Al-Junaidi. Can you hear me, Abdullah?
السلام عليكم.
وعليكم السلام. هلا عبد الله.
Prof, I am driving ترى يعني I can listen.
Okay, عبد الله. Okay, thank you, عبد الله.
I have questions, Prof, but I have questions.
I can hear you, عبد الله. تفضل.
Prof, regarding the first the canalicular laceration injury repair,
yes.
If there is a tissue loss and there is deformity near the canthal area, does this affect the outcome even with the mini-Monaca stenting? And will this change long-term يعني use of probe? يعني you will make it more than 2 months? This is question one. Question number two, regarding the dacrylith formation. We all know it is mainly it consists of epithelial cells, and there is also a possibility of superinfection. ما أدري what is your experience with superinfection in cases of dacrylith, and what kind of measures you will do differently in such patients?
Thank you, Abdullah. For the first question, the tissue loss actually it is overestimated. Most of the time there will be no tissue loss. You know, the tissue and the orbicularis muscle is retractile. So once you have any cut wound in this area, you'll find the tissue is retracted towards the fixed part. So you will have the feeling that there is a tissue loss, but actually there is no tissue loss. But if in case you have tissue loss, it depends. If the tissue loss is involved in the canalicular system, if involving one canalicular system, don't do anything. Just repair the area. If you can put a stent well and a good monocanalicular stent, but never manipulate the upper one or the other one, because 50% at least you will be sure that it is working, rather than to go and to do more and more problem and do induce fibrosis for the upper one. In this case, if you cannot put a monocanalicular stent because it has a collarette that has to be fixed shoulder within the ampulla of the canalicular system junction between the vertical and the horizontal one. If you have enough experience, you can put the big tail, but with gentle manipulation. If you haven't, you put the regular stenting, the bicanalicular stenting. But if it is difficult, don't vigorously manipulate the lacrimal drainage system. Okay? So to leave one functioning better than to damage the whole lacrimal drainage system. The second question regarding dacrylith. Mostly dacrylith, we diagnose it intraoperatively. It is rarely to expect dacrylith preoperatively, unless like the previous patients that I showed you, the history is clear from that. If the infection is there and you are expecting dacrylith, you can do ultrasound by microscopy. It will show the dacrylith inside. Predisposed to infection, it is not clear, is it dacrylith superimposed by infection from the clinical aspect of view, or it is chronic dacryocystitis, simple chronic dacryocystitis was positive regard. So it is difficult clinically to identify it is a dacrylith with infection. Usually, as I told you, you will find the stone inside the lacrimal sac intraoperatively, or if the question is raised, you might go from the history, you might go for ultrasound by microscopy. Okay, عبد الله.
شكرا جزيلا، واضح يا بروف، شكرا جزيلا.
عفوا يا عبد الله. So what is this image? Anybody want to take this one? And I see a lot of iPhones, but I don't know who is. Okay, Dalal.
Yes, Prof.
Dalal. So what do you think?
Okay, firstly, this is a dacrylcystography. I can see, I think the dye is already inside, and I can see on the left side, there seems to be obstruction superior, in the early on in the canalicular system, not reaching to the nasolacrimal duct.
Okay. So this is for anatomic obstruction or functional obstruction? The functional obstruction.
Functional, yes.
Usually we bought here the fluorescein or the dye, sorry, and we inject it inside. So yes. This is not functional. This is anatomical.
Okay.
The anatomical, we inject the dye and we expose the patient to X-ray, okay, and then photograph. Okay. Unlike the functional we inject or we both installed inside the conjunctival cul-de-sac radio-opaque material, and we take the radiation emitted from the dye itself. So we don't expose the patient to external beam radiation, but we recorded the radiation coming from, and this is what we are talking about. This is for
this is the functional? Okay.
Yeah. This is a dacryscintigraphy. Okay, so we don't inject, we just put the dye inside the conjunctival cul-de-sac, and then we will see the dye. You can see here the dye stopped here.
Yeah.
Okay, yes. So we take the gamma irradiation on a film. Clear?
So here, these are the cases where we expect it to be more of atony than actual
Yes. Yeah,
like
exactly.
obstruction.
Yeah, functional obstruction is the anatomically patent, but the patient is complaining.
Okay.
Like facial palsy, for example. Okay, thank you so much. And I think it's the time now is 10 o'clock. Okay, do you have any question? If you have any question, يا شباب. يا شباب. I cannot see here.
شكله كلنا شابات في اليوم.
Okay. طب Iman, if she's still with us, this is the last slide. Iman.
Yes, Prof.
Oh, what is this, Iman?
I know it, but صراحة I cannot recall the name. But this is most likely the balloon
Very good.
dacroplastis. Yes.
Very good, yeah. Seldom we use this one. The Down syndrome is a good indication to use the balloon dacroplasty. It comes in two sizes, and you have to inflate twice in different areas. Okay, it's inflated here, so this is the first landmark, and then you pull it and inflate it again with the second landmark. Very good. Okay, thank you so much, and I hope that you get benefit from these two lectures. Yes.
يعطيك ألف عافية Prof.
Any question? Okay. Good night يا شباب. السلام عليكم.